तो इमरान आप स्टार्ट करते हैं।
उसकी नजर आ रही है, शुरू करते हैं। Okay, our today's lecture is the second part, drugs used to treat hypertension. And in this lecture, we have these are the following objectives. At the end of this lecture, you must be able to identify or explain the role of different vasodilators that we can use to control hypertension, adverse effects of vasodilators, which are very important, mechanism of angiotensin converting enzyme inhibitors and angiotensin receptor blockers, describe the mechanism of dry cough, one of the important side effects of ACE inhibitors, and identify the name of a drug that can inhibit renin activity. So what we have done up till now, what we did in the yesterday class, diuretics and the drugs that can act on the sympathetic nerve. Now the third group, vasodilators, drugs which dilate blood vessels and decrease peripheral vascular resistance. And this point also we discussed yesterday. When there is increased peripheral vascular resistance, that is due to vasoconstriction, that will lead to increased venous return, and increased venous return, increased cardiac output, increased blood. Drugs which are responsible vessels will decrease the peripheral vascular resistance by acting on smooth muscles, so non-autonomic mechanism. Here, and when we say blood vessels, include both veins and vasodilator is the release of nitric oxide. Nitric oxide stimulates guanylyl cyclase and increases cyclic GMP in smooth muscle, and that will lead to reduction of cytoplasmic calcium by causing calcium sequestration in the endoplasmic reticulum, relaxation of both arterioles and venous that will lead to decreased peripheral vascular resistance and reducing cardiac free as well as artery. So, key mechanism that one of the mechanism is the release of nitric oxide, which increases the cyclic GMP levels due to stimulation of guanylyl cyclase enzyme. Second mechanism could be opening of potassium channel. And when there is opening of potassium channel, there is efflux of potassium, and that will lead that will produce the relaxation of the vascular resistance. The third mechanism that is involved towards the vasodilatation of the vessels is the blockade of calcium channel. Reduce intracellular calcium concentration, relaxes more. This activity is more with arteriolar smooth muscles than granular. That will reduce peripheral vascular resistance. Compensatory responses are preserved. This is important because this point also we discussed yesterday, that is called the reflex activity. When we are using vasodilators and there is vasodilation, that will lead to cooling of blood, decreased cardiac output, decreased blood pressure, and when there is decreased blood pressure, two important reflex activity. Number one, stimulation of sympathetic nervous system to increase the cardiac activity. And second, when there is decreased cardiac output, decreased blood pressure, decreased amount of blood will reach towards kidney, so it will stimulate renin, angiotensin, aldosterone system that will lead to salt and water retention. So that is why if we are using vasodilators, water retention or reflex tachycardia, it is suitable or it is recommended to give the combination or either with diuretic or beta blockers with vasodilators. We can classify broadly vasodilators into direct acting and indirect. Directly acting means it indicates it directly stimulates the. We have very important examples. For example, minoxidil, diazoxide, sodium nitroprusside, and hydralazine. So these are the very important examples of direct acting vasodilators. So that is why we are discussing over here. First example, minoxidil, that can be used for the treatment of severe hypertension that could be resistant to other drugs. Why it is not being used commonly is because of its side effects. So that is why the use of minoxidil is basically we reserve the therapy with minoxidil in resistant cases of severe hypertension. It's a product and its metabolite minoxidil sulfate is a potassium channel opener. This is important. The mechanism of action, and that will lead to hyperpolarization and it will relaxes the smooth muscles. More effect on arterioles than on veins, right? That means it can relaxes the arteries as well as veins, but more effect, predominant effect on arterioles. Orally active adverse effects again salt, sodium, and water retention. Why? Due to activation of renin-angiotensin aldosterone system due to decreased cardiac output. So co-administration with beta blockers is mandatory for this drug. Edema, it will cause edema. This is the point, that is the exam-oriented point. Which one of the following antihypertensive drugs uh, can produce hypertrichosis, excessive hair growth? That is also called hirsutism. Diazoxide, this is another drug, and generally it is used in emergency situation. Given by a rapid IV injection, and it will produce the effect less than 30 seconds in hypertensive emergencies. The mechanism of action, just like minoxidil, potassium channel openers. Okay, the next important point is because this dioxide that is very important. The important adverse effect related to this dioxide, it can be used in patients with inoperable insulinoma, in which excessive secretion of insulin that will lead to production of or state of hypoglycemic state or hyperglycemic state. Definitely, when there is increased insulin secretion, it will induce hypoglycemic state. So this dioxide can reduce the insulin secretion. Right. So this is one of the important, another important use of this type. Adverse effects just like minoxidil, sodium and water retention, hyperglycemia. Here you can see because now in insulinoma, suppose it insulin secretion is increased, and increased insulin secretion will lead to hypoglycemia. When we use diazoxide, it will inhibit the release of insulin, so it will induce the reverse state, that is hyperglycemia. Just like minoxidil, it can cause hirsutism. Another drug, hydralazine, very important drug. Rapidly and freely absorbed after oral administration and mainly decreases the arteriolar resistance. Useful for hypertensive crisis during pregnancy. This is important, this point. And yesterday I also discussed one of the drug is be used to treat the hypertensive emergencies or crises. And L-DOPA, centrally acting alpha-2 agonist, that can also be used in the treatment of pre-existing hypertension in pregnancy. And this hydrolysine, this is another example. Just like minoxidil and diazoxide, salt and water retention. Why? The mechanism already we have discussed. Systemic lupus erythematosus. So this is one of the drugs that can produce systemic lupus erythematosus, one of the side effects and one of the exam-oriented points. We are going to suspect when there is unexplained weight loss or arthritis. If a patient is using hydralazine and it presents a picture of unexplained weight loss and arthritis, so we can think about the systemic lupus treatment. This is another drug that is the sodium nitroprusside, short acting. So that is why one of the important drugs that can be used in the hypertensive emergencies, hypertensive crisis, administered by infusion in hypertensive emergencies, hypertensive uh, 24 hours. Because we'll have to keep the of cyanide. So cyanide toxicity can happen. This is one of the problem related to this sodium nitrate. Releases how it's going to produce vasodilatation, releases sodium nitric oxide, right? This already we have discussed three important release of nitric oxide that will is enzyme and that will lead to increased concentration of cyclic GMP and that is responsible for the relaxation of the smooth muscle of the bicep. Adverse effects: too rapid reduction of blood pressure. So this is another possible side effects, and sudden drop in the blood pressure that may lead to reflex tachycardia and salt and water retention. Okay, cyanide metabolite accumulation, tachycardia, hyperventilation, arrhythmias, and acidosis. Okay, this is all about the direct acting. Now, indirect acting. That means the calcium channel blocking agents that can be labeled as the indirect acting vasodilators. And two important groups. One of the group is dihydropyridine group, in which we have very important drug that is amlodipine that is being used commonly, and the prototype drug is nifedipine. And non-dihydropyridine group and two important examples, diltiazem and what they block voltage-dependent L-type calcium channel, relaxation of smooth muscle, vasodilatation, reduce peripheral vascular resistance, reduction of blood pressure. Negatively inotropic drug. This is important. What does it mean? That means if a patient having heart failure, so in heart failure, we are required the positive inotropic agent. So these drug is going to further slow down the heart activity. So we'll have to be very, very careful and should be given in heart failure patient. Orally active, suitable for long-term use. Dihydropyridine group, very important. One important point. Okay, calcium channel blockers, two major group. Dihydropyridine group, non-dihydropyridine group. In non-dihydropyridine group, we have two important examples, diltiazem and verapamil. Why I'm focusing on this point? This is important because dihydropyridine group on blood vessels, whereas non-dihydropyridine group in which we have diltiazem and verapamil mainly acting on heart, mainly acting on heart. So is there any clinical importance? Yes, because the calcium channel blockers which are acting on vessels, it will induces or increase chances of reflex tachycardia. Reflex tachycardia, right? And this problem is not going to occur with non-dihydropyridine groups which are acting to decrease chances of reflex tachycardia. So that is why uh, and when we say antiarrhythmic drug, classification of antiarrhythmic drugs, we have class 1, class 2, class 3, class 4. And class for antiarrhythmic drugs basically calcium channel blockers. So one student can ask the question, okay, calcium channel blockers, they are going to induce reflex tachycardia. So how we can use in the treatment of arrhythmia? Your answer would be, okay, we are not going to use dihydropyridine group in the treatment of as antiarrhythmic drugs, but we can use drugs that predominantly act on heart. So they are not going to produce reflex tachycardia, so there is no chance to produce arrhythmia. Okay, so this is the explanation. So dihydropyridine evoke vasodilation resulting in sympathetic reflex activation, relatively selective for vascular. Important example, amlodipine, longer duration of action, so one theory can be given. Do not reduce myocardial contractility, do not reduce clinical deterioration in heart failure. This is one of the important advantage of this group because in heart failure we cannot use dihydropyridine group which predominantly reduce the cardiac contractility or cardiac activity. Nimodipine, this is one of the exceptional point, preferentially acts on cerebral arteries, prevention of vascular spasm following aneurysmal subarachnoid hemorrhage. Indication, all grades of essential hypertension, alonifadipine, amlodipine in patients with mild hypertension for patients in whom thiazide diuretics and beta blockers are contraindicated. Combinations can be given, especially in angina with beta blockers. Now, this verapamil and diltiazem, basically, these two calcium channel blockers we can also label as dihydropyridine group, right? Effects on the voltage dependent channels in cardiac conducting tissue that will lead to vasodilation. It also blocks the calcium entry in gastrointestinal smooth muscles and consequently causes constipation. So this is one of the disadvantages of this dihydropyridine group, increased chances of constipation. This is another group. Okay, up till now, what we have discussed, uh, uh, diuretic, drugs acting on sympathetic nerves, vasodilators. Now, the again a very important group, angiotensin converting enzyme inhibitors or angiotensin receptor blockers. So, angiotensin converting enzyme inhibitors, important examples, captopril, enalapril, lisinopril, and other pril. Indications, hypertension, where thiazide diuretics and beta blockers are contraindicated. Useful in hypertensive patients with heart failure that will lead to beneficial effects, can limit the size of myocardial infarction, and especially one important point. This is the exam oriented point. Uh, Suppose there is a question, there is a scenario, and the question is asked, okay, which one of the following antihypertensive drug is supposed to be the group of first choice to treat hypertension in diabetic patients? So your answer would be angiotensin converting enzyme inhibitors or angiotensin receptor blockers. Okay, mechanism of action. Angiotensin converting enzyme inhibitors regulates balance between bradykinin, which is responsible to produce vasodilation, and angiotensin 2. Angiotensin, that is responsible to produce vasoconstriction and sodium retention. That also we have discussed yesterday. Because when there is decreased blood pressure, in response to decreased blood pressure, renin, angiotensin, aldosterone system is activated. Okay? Angiotensin act on angiotensin 1 receptor, widely distributed in the body, lung, tissue surface areas of endothelial cells, heart, kidney, striated muscles, and brain, and present on the liminal surface of vascular endothelial cells. Produces vasoconstriction and noradrenaline release from sympathetic nerve terminals, and very important point, aldosterone secretion, that is due to angiotensin. Aldosterone secretion from the zona glomerulosa of the adrenal cortex, ADH. This angiotensin 2 is a growth factor for vascular smoothness and some other cells. So it will induce the process of remodeling phenomena. So that is why this is one of the important groups that we consider in the treatment of heart failure or the diabetic induced hypertension to avoid or inhibit the remodeling phenomena that can occur. Okay, you can see normally what happens. You know, renin is going to activate angiotensinogen to angiotensin 1, and this angiotensinogen is produced in the liver. This angiotensin 1 is converted into angiotensin 2 with the help of an enzyme that is called angiotensin converting enzyme. And this angiotensin 2 is a powerful vasoconstricting agent, and already we have discussed this will also stimulate the activity of aldosterone, right? And this angiotensin 2 is produced at the same time. At the same time, what happens? There is production of inactive metabolites of bradykinin. This is important point because when we use ACE inhibitors, what will happen? There is no conversion of angiotensin 1 into angiotensin 2, right? And at the same time, there is no inactivation of bradykinin. So ultimately, what will happen? The level of bradykinin will raise. Okay, as far as the hypertension is concerned, this is important because bradykinin is a very active vasodilator. But this bradykinin may also create a problem. Specifically, if a patient having the asthma history, it may induce the dry cough. It may induce dry cough. So this is one of the important side effects of angiotensin converting enzyme inhibitors. And this is one of the commonly asked question, why this dry cough develop? When we use angiotensin converting enzyme, normally angiotensin converting enzyme is responsible to convert angiotensin 1 into angiotensin 2. The second important activity, conversion of bradykinin into inactive metabolites. When we use angiotensin converting enzyme inhibitors, what will happen? There is no formation of angiotensin 2, but at the same time, there is no inactivation of bradykinin, right? So the level of bradykinin will raise, and that will stimulate the process of dry cough. So this is another explanatory diagram and angiotensin aldosterone system. Now you can see from the juxtaglomerular cells of the kidney, renin is released, and renin is going to convert angiotensinogen into angiotensin 1, and this angiotensin 1 is converted into angiotensin 2 with the help of angiotensin converting enzyme, and this angiotensin 2 specifically act on angiotensin receptor 1 and will induce vasoconstriction, sympathetic stimulation, cellular hypertrophy, and renovascular effects, right? And also responsible to induce the activity of neuron. And the second, on the extreme left, you can see bradykinin. Normally, bradykinin is converted into inactive peptides, but when we use ACE inhibitors, this inactivity is not going to produce. So the level of bradykinin will raise, and that will induce the drive, right? Again, the mechanism of action of this angiotensin converting enzyme inhibitors or receptor blockers. Converting enzyme inhibitors lower blood pressure by reducing angiotensin 2. It's the main key mechanism. And also by increasing vasodilator peptides such as bradykinin, dilation of arteriolar, reduction of peripheral vascular resistance, blood pressure, and also increased sodium excretion, but decrease excretion of potassium. Why it is important? Why I am focusing on this point? Okay, it enhances the excretion of sodium. So when we enhances the sodium excretion, water molecule will also move along with sodium, right? decrease excretion. So this will lead to a state that is called hyperkalemic state. Decreased excretion may cause hyperkalemia, right? It also decreases noradrenaline release, so reduction of sympathetic activity. So use is not associated with reflex tachycardia. This is one of the important beneficial points despite causing arteriolar and venous dilatation. Inhibition of aldosterone secretion. So very important group. So what will happen? The general mechanism when we inhibit the activity of aldosterone, so we can prevent the salt and water retention phenomena. So we can reduce the fluid volume, so we can reduce the blood pressure. But very important point that what we are going to achieve by inhibiting aldosterone activity, it influence on the arteriolar and left ventricular remodeling that are believed to be important in the pathogenesis of human essential hypertension and post-infarction state. This point already I have discussed with you. Adverse effects and contraindications of angiotensin converting enzyme inhibitor are generally well tolerated. Adverse effects include first dose hypertension, particularly in those receiving diuretics therapy. The first dose should preferably be given at bedtime. But one important point I want to share with you. The first dose syncope is more more related to which group? More related to alpha 1 blockers that we discussed yesterday that may induce the orthostatic hypotension because this stimulation of alpha 1 receptor is responsible to produce vasoconstriction that prevents the postural hypotension. When we block these receptors, so there is a chance to produce postural hypotension, right? Okay, dry cough is also this important side effect already we have discussed. Dry cough, the most frequent 5 to 30%. Symptoms could be reduced by treatment with Sulindac, that is the prostaglandin inhibitor, or belongs to NSAID group. But another option is we can replace this angiotensin converting enzyme inhibitor with angiotensin receptor blocker. So when we use angiotensin receptor blockers, we are not going to disturb the activity of bradykinin, right? How? We are not going to disturb the activity of angiotensin converting enzyme, right? So what will happen? There will be inactivation of bradykinin. So in dry cough, we can use angiotensin receptor blocker as alternative. This angiotensin converting enzyme inhibitors may cause urticaria and angioneurotic edema due to increased tannin concentration. Functional renal failure occurs predictably in patients with hemodynamically bilateral renal artery stenosis. And in patients with renal artery stenosis in the vessels supplying a single functional kidney, though they protect the diabetic kidney, renovascular disease. Fatal injury result in oligohydramnios, craniofacial malformations, so that is why contraindicated in pregnancy. One important point here I want to focus. There is only one difference when we compare with angiotensin converting enzyme inhibitor and angiotensin receptor blocker, that is the dry cough. Otherwise, side effects, contraindications, both are similar, right? Whether we are using angiotensin converting enzyme inhibitor or we are using angiotensin receptor blocker. Hyperkalemia, this one also we have discussed one of the side effects because angiotensin converting enzyme inhibitors, they are going to enhance the secretion of sodium but prevent the secretion of potassium, so it may lead to hyperkalemia. So any drug that can increases the potassium level, it's very important to monitor this. Uh, if we are using the drugs simultaneously or what is the important drug interaction because angiotensin group may produce hyperkalemic state. So, if a patient is taking another drug, that is also responsible to produce hyperkalemia. So, that will induce the marked hyperkalemic state. Angiotensin converting enzyme inhibitors cause a modest increase in plasma potassium as a result of reduced aldosterone secretion, and this may usually counter the small reduction in potassium ion concentration caused by thiazide diuresis. Potassium accumulation may be marked, especially if the patient is consuming high potassium diet or potassium-sparing diuretics. Important examples are spironolactone and eplerenone. Under these circumstances, potassium concentration may reach toxic levels, as it is in patients with renal impairment specifically. Now, angiotensin receptor blockers and important examples are losartan, valsartan, irbesartan, and other sartans. The receptor blockers competitively inhibit angiotensin II at its angiotensin type 1 receptor site. These drugs lower blood pressure as the angiotensin converting enzyme inhibitors and have the advantage of much lower incidence of adverse effects resulting from the accumulation of radicals. What is that? Cough, dry cough, and angioneurotic agents. So this is one of the key difference. Sorry. They cause fetal renal toxicity like that of angiotensin converting enzyme inhibitors. These drugs reduce aldosterone levels and cause potassium accumulation and attainment of toxic level hazardous in patients, especially with renal failure patients. This is another very important example. And what is that? What is the name of a drug that can inhibit the renin activity? That is the aliskiren. That is the drug that can inhibit the renin activity. So why we are interested to inhibit the renin activity? Because renin is responsible to convert angiotensinogen into angiotensin 1, and there is a activation of a system what we label as the renin angiotensin aldosterone system. So if we inhibit this renin, so we can inhibit this renin angiotensin aldosterone system. So renin inhibitor aliskiren, that's this very important example. Okay, so we just uh, there is another important point that we can discuss right now: hypertensive emergency management of hypertensive emergency. Right, one of the major problems, especially during pregnancy. So one important point I want to share: if there is pre-existing hypertension in a female, right? What does it mean? The patient is pregnant but having hypertension, high blood pressure problem before before the pregnancy. That is called the pre-existing hypertension. So in that situation, we can use methyl-dopa, or there is another drug that is the labetalol. This labetalol is one of the drugs that can also be used in hypertensive emergency during pregnancy. There is another condition that is called preeclampsia. What is that? This preeclampsia. Preeclampsia when there is new onset of hypertension after pregnancy. So in this condition, hydralazine and levodopa, these are the preferable drugs. So these are the drugs that we use specifically during pregnancy, but as a general, in the emergency hypertensive crisis management, we can use sodium nitroprusside, uh, diazoxide. This also we have discussed, levodopa, right? And another very important drug that acts on dopamine T1 receptors, that is called the phenolphosphate. So these are the drugs that we can use to control blood pressure during emergency. Thank you very much. So this is all about the drug use to treat hypertension. Hello, hello, hello. believe now? Hello, hello, hello.